And we are live now.
Good evening to one and all of you. A very warm welcome to you all for this eye education webinar, which has been essentially conceptualized to enhance the portal of education with greater learning on very practical, relevant aspects. And today we are on to strabismus. We are truly lucky to have the experts in the fields to lead us in the next couple of hours. Dr. Murli, Dr. Hamid and myself would be moderating the session. I would be introducing Murli to you again. Dr. Hamid is a consultant in the Eye Foundation group of hospitals from Bangalore. He specialized in orbit, oculoplasty, and pediatric ophthalmology and adult strabismus. After his post-graduation and residency at All India Institute of Medical Sciences, New Delhi. We are truly enlightened to have with us today Dr. Ellen Spielman, a renowned pediatric and neuro-ophthalmologist with special interest in the diagnosis and treatment of strabismus, nystagmus, and oculomotor palsies. He has over the years brought in very many innovative techniques and is presently the counselor of the International Strabismological Association. Dr. Allen would be talking on avoiding undesirable and unexpected outcomes in nystagmus surgery. On to you, doctor. We look forward to learning more from you.
Thank you. Well, I suppose everybody can see my slides now? Yeah. All right, so I'm going to start. I will talk about preventing and managing undesirable results in infantile nystagmus strabismus. If we think about the goals of surgery, that is to dampen nystagmus intensity and to improve visual acuity by doing so, and also to improve head turns. Undesirable results means to have lack of efficacy regarding our surgery or undesirable changes about head turn, that is overcorrection, undercorrection, or recurrence of the head turn. But we also have to deal with complications of surgery. I will not talk about non-specific complications, that is scleral perforation, scars, slippage, muscle loss, infection. That's not the topic of the talk today, but I will talk about a few more specific complications related to the techniques of strabismus surgery, especially consecutive strabismus, anterior segment ischemia, or lead changes. To start, I want to talk very briefly about the basic surgical techniques, just to make sure everybody understands what is nystagmus surgery. The main procedure is the Anderson-Kestenbaum procedure. When surgery is on two muscles, is usually a recession of one muscle on each eye. This is Anderson procedure. And when we add two more muscles, that is resection of the two other muscles, this is the Kestenbaum procedure with a surgical dosage, usually around 6 to 12 millimeters, depending on the habits of the surgeon and the degree of the head turn. The other basic technique is artificial divergent surgery, which is often called bimedial recession, BMR, in the United States. Usually the recession is less, that is a recession from 5 to 8 millimeters. And I will show an example of the indication. This is a boy with nystagmus with blocking convergence. You can use glasses to see whether the nystagmus dampens when putting the eyes on a divergent place. And this is done by prism adaptation test. And if the prisms do so, the surgery will do the same as the prisms. The other basic surgical technique, which is less popular, is the large recession of the four horizontal rectus muscles. And the amount of surgery is usually much more, from 10 to 12 millimeters, if you want to be effective. Here is a case before surgery, and after surgery, nystagmus is less intense in terms of amplitude and maybe in terms of frequency. The last technique is sternotomy reattachment. I don't have a lot of experience with this technique, so I will not talk a lot about it. I suppose there is no surgical complication, and the main undesirable result could be the absence of efficacy. So let's start with lack of efficacy, which is seen not only after TNR, but also after artificial divergent surgery or large recession of the 4 horizontal muscles. I think there is never a total lack of efficacy if you do a Kestenbaum surgery, because you will always have efficacy on the head turn. But now we're talking about lack of efficacy regarding the intensity of the nystagmus and the visual acuity. And sometimes when it happens, the parents, it's the parents or the adult patient, in case the patient, the operation is on an adult. So it's the parents or the adult patient who say there is no change and that vision is not better. So it's not a complication, it's just a disappointing result. And in fact, it's difficult to assess and compare accurately pre and post-operative intensity and visual acuity, because in the office, when we examine patient, nystagmus will vary depending on fixation efforts, depending on tiredness, anxiety, and it may vary from one day to another day. So I believe we have to trust the parents if they say there is no change. But it's difficult to evaluate objectively the effect of surgery, and even recording of the eye movement does not help, because when you record the eye movement, even it's supposed to be an objective exam, it depends on fixation effort, synod, and the other parameters. So we are not always sure that it's really lack of efficacy, because there are possible less obvious benefits of surgery. I mean that visual acuity is not the only component of vision. Vision is also recognition time, speed for reading, fatigue when making visual efforts. And in practice, we have to believe that these patients who are disappointed, in fact, have improvement of fovation time, and we can see late improvement of visual acuity even in adults if we wait sufficiently long. I mean, months or years after surgery, we can clearly see that visual acuity had improved by time going. So if we have a disappointing result on the nystagmus intensity, we will have to communicate with the patient or with the parents. Maybe they're right, we have to trust them, but maybe it's not such a bad result. Now we move to over or under correction of head turns. In case of Anderson-Kestenbaum procedure. What I call overcorrection of head turn is an opposite head turn following surgery, the head turn in the opposite way, due to too large surgical dosage. A transient, and this is accompanied with gaze limitation. A transient overcorrection of head turn can happen after Kestenbaum surgery in the days after surgery, and it will last for a few days or a few weeks and will resolve spontaneously. This is not a complication. What I really call overcorrection is persisting overcorrection over time. In fact, this is rare, and it's associated with limitation of lateral gaze, because there is a leash effect due to tight rectus, and you may have also a vertical deviation associated with tight rectus. I will show you a video next slide. And if it happened, the management may be to let the thing like this. Patient does not necessarily complain because they're happy with the results on the intensity of the nystagmus. But if the limitation of gaze is too much, you can recess the tight muscles. It's not a problem. The prevention to avoid such overcorrection, it comes with experience. The feeling, as a surgeon, the feeling about how much muscles can be recessed or resected come with experience. I don't believe that the force reduction test at the end of surgery could help to know if we will get overcorrection. I mean, in the superior oblique tuck, you can do you can do a force reduction to know whether you will have a Brown syndrome. But on horizontal muscle, the value of the force reduction test at the end of surgery, in my opinion, is not really worth. I just want to show a video to show what is tight lateral rectus. This is not a man with nystagmus. He had a long-standing strabismus. And just to show that in adduction, this eye shows vertical deviation, so such like a superior oblique overreaction, but it's due to tightness of the lateral rectus. And if you have an overcorrection after nystagmus surgery, you can find such features. You can also have an opposite head turn after surgery, but without lateral gaze deficit. And in my opinion, it is not really overcorrection with too much amount of millimeters of surgery. If this happens, this is usually unmasking a pre-existing head turn, which was not taken into account before surgery. If this happens, maybe you can let it be. But if you decide to reoperate, it's usually easy to recess the previously resected muscles. Prevention is of utmost importance, and you will have to look at the situations listed on the next slide. And before planning surgery, you will have to ask the patient or the parents of the child, you will have to ask again and again if they can see two head turns in daily life, in daily life, sometimes to the left, sometimes to the right, before deciding whether you will do a custom bone surgery, and if any doubt, prefer Undesirable on two muscle or choose artificial divergent surgery, or even reset the 4 horizontal muscles if there are 2 head turns. So what you will have to search before surgery is periodic or aperiodic alternating nystagmus. Now, in this young adult, nystagmus is blocked on right gaze, and after a few minutes, it will change. The head turn will change, and you will see another head turn, and nystagmus getting worse in the right gaze. This situation is not unusual in albinism, so take your time to examine patients. Another situation, which is not so rare, is two opposite head turn, one at distance fixation and the other one at near fixation. Here, this girl is reading at distance, and when reading at near, the head turn changes. You will have to look at this situation, and often these types have a blocking convergence. This is not always the case, but often this will be like the case, and you will choose artificial divergent surgery instead of Anderson Kestenbaum surgery. Another situation is nystagmus related to early strabismus with nystagmus and head turn depending on the fixating eye. You can have association of infantile nystagmus syndrome and fusion maldevelopment nystagmus syndrome. In the last video, you can see this girl with latent nystagmus which get permanent after occlusion. This is a manifest latent nystagmus. This is asymmetrical. And you can see DVD, also vertical deviation under the screen. And she had preferential fixation on induction with a dominant eye, which is the right eye. That explains the head turn. But you can make her left eye being fixating if you ask her to change, and the head turn will be the opposite. This is a situation where you will have to be careful regarding the main head turn and the other less frequent head turn. Sometimes you have undercorrection or recurrence of the head turn in the same direction. And persisting head turn just after surgery, head turn in the same direction, is due to insufficient dosage. This is undercorrection. This is not unusual. Recurrence of head turns months of years after surgery is probably due to other reasons, brainstem changes or muscular remodeling. And this is not due to insufficient dosage. But whatever the cause, whatever the reason, the management is the same. You will have to plan a second surgical step with enhanced surgical numbers. Prevention depends, in fact, on your results. If this situation happens frequently in your practice, so enhance your surgical numbers and choose Kestenbaum rather than Anderson procedure. Here is a case of a boy with nystagmus getting worse in the right gaze. So he puts his head like this with a right head turn. This is the way he is. I operated on with what I think sufficient dosage, what I thought was sufficient, 7 millimeters of recession and of resection. But 3 years later, he had the recurrence of the head turn with the same degree of head turn. And the simplest solution is to resect more the muscle that had been already previously resected. If the muscle were resected, had already been recessed 8 or 10 millimeters, it will be difficult to do more. So prefer resection of already resected muscles. In nystagmus surgery, you can also get consecutive horizontal strabismus, sometimes with diplopia. Surgery of head turn with Anderson Kestenbaum procedure rarely leads to consecutive strabismus because these patients are binoculars and they have good fusional capacities. And in practice, I think you don't have to make asymmetrical dosage on the lateral rectus and on the medial rectus, even if this is sometimes recommended. You can do whatever you want. Consecutive strabismus is fairly rare, fairly scarce after Kestenbaum, Anderson Kestenbaum procedure. After artificial divergent surgery, that is usually bimedial recession, you can get autophoria even after large dosage. That is due to muscular adaptation after surgery. Sometimes you get exophoria controlled by fusion, and this is still a good result. And maybe exophoria leads to a better control on nystagmus than orthophoria. The problem comes with exotropia, which cannot be controlled by fusion. And this is a bad result which requires another surgical step. So the prevention is to do prism adaptation test, which can last only a few minutes in the office, but if you have doubts, you can prescribe the glasses and to make the prism worn for a few weeks or a few months before deciding artificial divergent surgery. The large recession of the 4 horizontal muscles frequently leads to exotropia, probably around 10 to 20%, and that's too much. And if this happens, this requires another surgical step. To prevent this situation, you will have to recess less the medial rectus than the lateral rectus. But even in doing so, you will have a rate of consecutive exotropia, which will be less, but will be maybe around 10%, something like that. It does not happen just after surgery. It happens weeks or months after surgery. Even if you have a good immediate post-operative result, you will have to be careful about exotropia. I usually use adjustable sutures, and that this probably reduces the rate of consecutive exotropia. You will not have immediate consecutive exotropia, but sometimes you will get late exotropia. That's not a problem. You will then have to re-advance to a previously recessed medial rectus. A tip, which is for any kind of surgery, Anderson Kestenbaum, artificial divergence, or large recession, use adjustable suture. It will give you confidence, and you will be more confident to use large amount of surgical numbers. Don't hesitate to do 10 millimeters recession, or even sometimes 12 millimeters, and you will have good results on nystagmus if you do large amount of surgery. Another type of consecutive strabismus is A and V pattern strabismus after a vertical Anderson or Kestenbaum procedure. When you have a vertical head turn, chin up or chin down head turn, you will do surgery on the superior rectus. For example, in that boy, you will recess the superior rectus muscle and resect the inferior rectus muscle. Sometimes one step, sometimes 2 steps. And this will lead to induce cyclotorsion, because the vertical rectus muscle have effect on cyclotorsion. So cyclotorsion mean A and V pattern and elevation or depression in lateral gaze. And people can be really uncomfortable with diplopia, which change on the different positions of gaze. Cyclodiplopia cannot be treated by prism, and management is always difficult. You will have to operate again to undo what was done and to find ways to treat torsion. To prevent this situation, rather than going on the 4 vertical rectus muscle, you can operate on the inferior oblique, recess the inferior oblique muscle combined with the recession of the superior oblique, or you can recess the superior oblique muscle combined with the inferior rectus muscle, so that the action torsion will be balanced. There was a way to prevent these alphabetical pattern is to shift laterally the insertion of the vertical rectus to counter the torsion. This is to remind you the incyclotorsion effect of the superior rectus and the excyclotorsion of the inferior rectus. So you can use you can act on the inferior oblique instead of acting on the inferior rectus, and conversely on the superior oblique if you want to counter the torsion. Otherwise, if you operate on the superior inferior rectus muscle, you can shift the insertion to counter the torsion as well. Another undesirable result is late overcorrection and lead changes after recession of the inferior rectus muscle, because the inferior rectus is a tricky muscle. Late overcorrection can occur 4 to 8 weeks after surgery. This is a kind of slippage of the muscle due to poor adhesion to the sclera. The inferior oblique muscles may have a role because when the inferior oblique acts, it twists the inferior rectus muscle. There are also problems with carrying with Lockwood ligament. And this is a well-known complication of inferior rectus surgery. In nystagmus surgery, usually you recess the two inferior rectus symmetrically. They are equally recessed, but late overcorrection can be asymmetrical and it will lead to vertical strabismus and diplopia. Management usually is done first with vertical prisms, but reoperation will come next, and you will have to decide whether you will operate in shortly in the first weeks after the vertical deviation occurs, or if you want to wait for 6 months to have no more inflammation before going back to the operation site. There are many ways to prevent the inferior rectus slippage. I will not make a list of all what has been suggested. My preferred choice is to use non-absorbable suture. And if I do a vertical Kirstenbaum surgery on the inferior rectus and on the superior rectus muscles, I usually will use an adjustable suture on the superior rectus rather than the inferior rectus, because adjustable suture is a risk factor for late slippage of the muscle. Be aware that the inferior rectus recession usually leads to lower lid retraction, and to be efficient on nystagmus, you will have to do large amount of surgery. So you may have a large lower lid retraction. There are many tips that have been suggested to prevent lid retraction, such as advancement of the capsulopalpebral head of the ligament, or lysis of the retractors in the same time by a conjunctival incision to recess the retractors of the inferior lid. This is just to show late overcorrection with lid retraction and scleral show, just to remind you that there are adherences between the inferior rectus and the Lockwood ligament, and there are interaction between the inferior oblique and the inferior rectus muscle. This is an explanation why the inferior rectus does not adhere to the sclera firmly after inferior rectus surgery, and this is an anatomy of the capsulopalpebral fascia of the and the retractor, which are linked together, and they are also linked with the inferior rectus. And any scar between the inferior rectus and the lockwood ligament may lead to overcorrection. Anterior segment ischemia is seen infrequently because we take care of this. This can occur if too many rectus muscles are operating on, especially in this situation. Horizontal and vertical head turns, which can be operated on in the same surgical step, or operation can be delayed over time. But sometimes you will also have nystagmus and strabismus associated together, and surgery will be on horizontal head turn and vertical strabismus, or vertical head turn and horizontal strabismus, and you will have to cut many rectus muscles and cut the ciliary vessels which go through the muscles, and it can lead to anterior segment ischemia, inflammation, iris changes, and sometimes visual loss. The prevention, there are ways to prevent, and there is less risks in young patients. First, you have to wait a sufficient delay between two operations, because you will give time for vessel to develop. I don't find the word, but I think you understand. Collateral vessels to develop. Try to avoid limbal incision, because conjunctival vessel may help for irrigating the anterior segment. Choose plication rather than resection, because when you plicate a muscle, you can spare the ciliary vessels here. And if you are a really good surgeon, you can try to preserve these vessels by careful dissection and a recession without cutting the ciliary vessel. But it's a difficult surgery, and in practice, sometimes you can cut inadvertently the vessels. To sum up all what I said, undesirable results depend on the type of surgery, and if I have to choose one main undesirable result for each surgery, for horizontal anterior custom procedure, the main problem is undercorrection. On vertical anterior procedure, the main problem is induced cyclotorsion. The main concern after after artificial divergent surgery is exotropia. The main problem after large recession of the four horizontal muscles is exotropia also. And after tenotomy and reattachment of the muscle, the main problem is apparent lack of efficacy. Remember that the more you want to be effective on the intensity of the nystagmus, the more you will have to have large surgical numbers, and the more you risk undesirable results. So there is a balance, a choice to make, to be efficient or not, and to accept a part of risk. I think good general knowledge about strabismus surgery, extracortical surgery is useful. Maybe for experimented surgeons, this is basic to know about anterior segment ischemia, to know the tricks on the inferior rectus and the links with the lid. But it's not, maybe an experimented surgeon does not necessarily know that, and they have to know this for if they want to have good results and not to have unexpected results and complication after nystagmus surgery. And in my hands, adjustable surgery is useful, not in young children, but in older children and in adults. Thank you very much for your attention.
Thank you very much, Doctor, for such an information-packed talk in the last few minutes. I would ask one or simple questions before we go on to Murli and Hamid asking more. Is there any role of using brinzolamide for any residual head turn from these infantile nystagmus, or it has no role at all?
I'm sorry, is there any rule for what? I didn't understand your question.
Role of brinzolamide.
Brinzolamide. Well, I prescribed it 2 or 3 times, and the patient never come back. They never came back. So I don't know. I don't have a personal experience about it, but maybe it's just useful. Do you have any opinion about this?
Dr. Murli would also agree on that, no? Hello, Murli, you're muted. Dr. Murli?
Yeah. I also tried on a couple of patients, but I also didn't get a very remarkable result after that.
More of a general question. What would be your special consideration for testing vision in these patients with nystagmus? Would you look at instead of doing?
Well, testing vision. Anyway, you will have to test vision in primary position with the head straight, and you will have to test the vision in position of head turn. What we want to obtain by surgery is to get surgery. It is to get the same vision in primary position as in the head turn, and sometimes it gets even better because, especially those who wear glasses, if they turn the head, they will not have optimal vision because vision will be on the edge of the glass. Astigmatism is different. There are optic aberrations. Sometimes you get better results after surgery. You can see vision improving after surgery and getting better in primary position than it was before surgery in the position of head turn. What I understand in testing vision is also, I can imagine that people who turn the head like this have a short visual field of attention. If you turn your head like this, you will have attention of what is going on your left, on the side here, and you will neglect what happened on the other side. And if the head is straight, this is not only improval of visual acuity in terms of lines of visual acuity, they get better visual, useful visual field. And this is not only visual testing. In fact, I do not, I do not really believe I believe in visual acuity testing, but we can relativize. It is not the only criteria to assess our results, and people get happy even if visual acuity is the same after surgery.
In other words, you would give priority to binocular vision than a monocular vision test.
Always both monocular, each eye, and binocular. And if you test monocular, you will have to assess also if there is a different head turn depending on the eye that you are testing.
But if a person has had a lot of neck contracture because of head turn, how would the results of the surgery be when you're doing surgery in an adult nystagmus?
I'm not sure adults have contracture, a real contracture. Let me explain. They often have pain after 40, when they are 40 years old or 50 years old. Probably they have pain because of arthrosis, contracture, and they complain about it. But in young adults, it's not the case. But even if they have contracture of the muscles of the neck, after surgery, they get their head straight, just like in children. I don't think the contracture make the head turn permanent. Maybe I will have to check more if they have contracture. I have to say that at least half of my patients are adult patients regarding distinguished surgery.
Yes. Dr. Pradeep Sharma, you have anything to add?
Yeah, I think Dr. Spillman has already covered a vast area. Yeah. And I think there are certain interesting points that he has made about, I mean, particularly like artificial divergent surgeries, we are not doing much. I have seen Dr. Annette Spillman's NAP lecture, I think in 2000, where he had described the artificial divergent surgeries, but he had also said that many of them had exotropia, which was recalcitrant, which was very difficult to correct even later on. So I think that's one thing we have to keep in mind when we do large bimedial recessions. Bimedial posterior fixations may be used in some cases, but they don't have much effect in nystagmus control. As far as the large four muscle surgeries that Dr. Spillman talked about, we do not have much of problems of exotropias because we do equitable amounts of surgery on medial and the lateral rectus. There are people who do equal amounts on the medial and the lateral rectus. I think that would lead to exotropias in large number. But what we do is always do equitable amounts, meaning that my largest medial rectus would be 9, lateral rectus would be 12. So in the ratio of 9 and 12, and we hardly get any exotropias in four muscle surgeries when we do this, because we are equitably recessing the medial and the lateral rectus. So that is one thing that I would differ. And as far as the adjustable surgeries, I think he's right. Whenever you're in doubt, you can do an adjustable surgery. But here, I think because we are doing large recessions, you should do hemi hangback. I would rather do a hemi hangback rather than a full hangback, because there is a creeping forward if you do more than a hangback of 7 millimeters of recessions. So you should do a hemi hangback. That means you might do a part of it which is adjustable, which is hanging. Rest is stitched to a sclera little farther.
Yeah, that's a good idea. Probably, yes.
And regarding the head posture in the adults, we have operated on adults, and as Dr. Spillman was saying, that the head posture gets corrected. It is not a permanent head posture. It gets corrected even in adults. I mean, that contracture of the neck muscles is not a problem in these cases we see. Partly because most of them are having face turns and not a head tilt. The people who have torticollis, the head tilt ones, maybe having more of a contractural problem of sternocleidomastoid, but the face turn ones are easily corrected fully. For the people who have a torticollis, we prefer to do the oblique muscle surgeries, the 4 obliques, to correct the cyclotorsion, rather than the vertical recti as described by von Nuden. I think I prefer to do the 4 oblique muscles because I would rather preserve the recti muscles for any strabismus which may be there associated. I wouldn't like to sacrifice the vertical recti for that purpose.
Dr. Murli, Dr. Hamid, you all have anything to ask before we go on to Dr. Pradeep Sharma's talk?
We have an audience question for Dr. Spillman. So that is, how do you manage a head turn with a head tilt? Would you correct the predominant face turn first, or would you do it as a stage procedure, or would you do the horizontals and obliques together?
Well, it's a very difficult question to answer. There are several ways to try to treat head tilt due to nystagmus. We can operate on the oblique muscles. We can operate on the rectus muscle with a shift. It's difficult to do the same amount of surgery on the left and on the right eye if you operate on the oblique muscle, because a recession of the inferior oblique on one eye and a recession on the superior oblique on the other eye is difficult. It's difficult to get the same amount of induced torsion. So for practical reasons, I feel more comfortable with shifting the insertion of the rectus muscles, but maybe it's not as efficient. And in fact, I will change my way to do depending on my mood, on the patient. One day I will prefer operating on the oblique muscle. The next day I will prefer to oblique on the rectus muscle. And sometimes I will be cautious and say the patient or the parents that maybe the child is not it's not such a problem, and we have to wait and see before going for surgery. I think there is no simple way to do so. Fortunately, it's not a frequent situation.
And how do you?
Head nodding among the moderators, so they agree with me.
Yeah.
How do you dose your artificial divergent surgery? Does it depend on the fusional convergence? You said it's 5 millimeters or more. So how would you dose your artificial
Yes,
divergence?
I think less than 4 millimeters is not really useful. If the patient has really good fusional reflex with good fusional convergence, you can see it immediately in your office. You can put the prism bar and put 30 diopters. They will immediately fuse and no longer have DPL. Even with 30 or 40 diopter prism, you can go for 6 to 8 millimeters. In adult patient, I will go for 8 millimeters with adjustable suture. And the surprising result is that they are often orthophoric the day after surgery. So there is a muscular changes and fusional convergence is very strong in this patient. And consecutive exotropia is not so frequent, I think so. If I have doubts, if I can't use adjustable suture, and that's the case in young children, I mean less than 8 years old, I will be more cautious and go only for 5 millimeters. And if this is insufficient, I know we can do more when they grew up. And I tell the parents that maybe a few years later, I will do a little bit more. When you want to assess the result of artificial divergent surgery, at first you may be disappointed because at distance fixation, nystagmus is not always dampened. But if you carefully assess the blockage in convergence before surgery and see that the nystagmus is dampened at, let's say, 20 centimeters from the nose before surgery, but after surgery, it's dampened at 50 or 60 centimeters, it will help a lot the child, because his visual field with a nystagmus in depth is much larger, and it will be not only for reading at 20 centimeters, but also for the screen of the computer or for writing on with the pen on the table. And I advise you to check this to assess the efficacy and the result of artificial divergent surgery, not only to look at this, how nystagmus is dampened at far fixation, but only at distance and intermediate, at a near and intermediate distance.
You had mentioned shifting of the vertical recti for vertical Kestenbaum-Anderson type of procedure. That is when you do a combined inferior and superior rectus recess resect procedure. So which muscles do you shift? The resected muscle or the recessed muscle, or all of them you shift?
It's easier to shift the insertion on recessed muscles. because usually I don't resect the muscle, I do plication. So it's difficult to plicate the muscle and shift. So I shift the recessed muscle and I plicate without shifting the other muscle. But if you do resection instead of plication, it does not matter whether you shift the recessed or the resected muscle. Or you can combine if you want.
So,
You
shall
had
we
mentioned,
you have more questions, Dr. Murli?
yeah, Hamid can put in, then we can reserve the rest of the questions for discussion. Hamid, you want to add something?
There's one question. How early do you operate on a nystagmus patient? And how do you manage amblyopia in a case of an esotrope or a strabismic amblyopia with manifest latent nystagmus?
The question is about patching, which make the nystagmus worse. That's right. That's how I understand.
Yes.
If there is amblyopia in early strabismus and manifest latent nystagmus, patching will make the nystagmus worse. So you can overcorrect the glasses with a +3 glass, and it will not have the same effect on the manifest latent nystagmus. I think this is the simplest way. Some authors, some other people say if you patch and if the nystagmus get worse, if you wait for a few days or a few weeks, the nystagmus will improve. In fact, does not get worse. I don't have any personal opinion about this because I try to avoid, but maybe you can patch without fearing the nystagmus to get worse. There was another question.
How early do you operate on a nystagmus patient? How early?
How early? It's rare. It's not frequent that I operate under the age of 2 years old. Usually I wait for 3 to 4 years old to operate. But if the head turn is really important, from time to time, I can operate before the age of 2, but never before the age of 1. But sometimes I do it before the age of 2, and usually I do only on 2 muscles, not on 4 muscles, just to be able to operate fresh muscles later.
Amit, any other question?
That's it, ma'am. That's it.
Thank you very much, doctor, for all that. We would come back to you again. We shall now go on to our next speaker, Dr. Pradeep Sharma. As we all know, is a professor and head of the Department of Pediatric Ophthalmology, Strabismus and Neuro-Ophthalmology at RP Center, New Delhi. He had completed his fellowship from advanced centers of training in US like the Wills Eye Hospital, was a visiting faculty in Orbis. He was the first Asian to have been invited to deliver the Knapp Memorial Lecture at Appos, Vancouver, 2016. He has been the recipient of the Achievement Award of AAO 2017, AIOS Rangachari Award, the Arthawale Award, and several state awards. He has over 150 publications, has authored textbooks, has been the past president and the founder member of SSI and SPSI. We are indeed lucky to have him sharing his pearls with us today. Dr. Pradeep Sharma would be talking on optimizing surgical results in paralytic strabismus. On to you, Doctor.
Thank you, Dr. Chitra. It's always a pleasure to be in a webinar because you conduct it so nicely and you have select speakers, but also giving them good time. So it's a pleasure to be talking on these important subjects. Today, the topic is optimizing surgical results in paralytic strabismus. Whenever we have paralytic strabismus, these children walk in with head postures and they are eager to get the eyes corrected because that's giving diplopia to them. And as we talk about that, our goal for ophthalmologists is to restore the binocular vision. And to restore the binocular vision, we have to restore the alignment. It is not only in children that the binocular vision gets affected by paralytic strabismus. Studies have shown, like in JPOS by the Stager group, that even in adults, if the misalignment is more than a year, there will be the binocular vision limitation forever. So we need to be correcting not only in time, but also a full alignment. How can we do that? We'll be talking about these. Now, let's say a girl comes in with a face turned to the left. We see that there is a left sixth nerve paralysis, and that is causing an esotropia in the primary position, and limited abduction is there in the left eye. How can we correct it? The first thing is that if the eyes are coming up to the midline, we would be preferring to do a resect or a recess plication procedure. And whenever we have such demanding patients in which diplopia is a problem, we would rather do an adjustable recession. And as I would show, sometimes it becomes very, very important. Like this individual who was 32 years old, came with 6-6 vision, 6-12 vision. He had a trauma 5-6 years back with intracerebral hemorrhage. He partially recovered sixth nerve palsy. He had an esotropia of 35 prism diopters. But importantly, he also had a bitemporal hemianopia because of the trauma. He did not have any diplopia at the time of presentation, but that was because he was having an esotropia and he had a bitemporal hemianopia. The moment you straighten his eyes, he will, and if you get it little overcorrected, he would be complaining of diplopia. So this is a practical problem. And in such cases, adjustable surgery is a very handy tool, as we did in this case. We had done a left lateral rectus plication of 8 millimeters, and the medial rectus, I put it on an adjustable of 6 mm for correcting that. But post-op, 5 hours later, I found that it was giving him diplopia. So I adjusted the muscle, brought it to 4.5 and then finally to 3.5 millimeters when the diplopia was resolved fully. And he is now a happy man because his diplopia is corrected, his head is straight, and he has the eyes are also straight. Strengthening procedures, now, as Dr. Spielman also had mentioned, more and more we are resorting to application rather than resection. So and this is much more so in paralytic strabismus, because we may have to do more than 2 muscles at times. And if you have done application on the paralytic muscle, it would save the anterior segment blood supply for doing the other procedures. So I think it's important to learn plication, and the reinforced plication that we talk about is something which is very handy whenever we are going to do a strengthening procedure on the muscle. So this is just a small video. I think Hamid was there and making this, editing this video. I would like to thank him once again. So this was the reinforced plication, and we had presented this at the American Academy in 2018. So you can see it's neatly, we just fold it on an iris repositor with these 6 vicryl sutures, and you can have a opportunity to even undo the procedure in the first week itself. Coming to the more difficult cases of paralytic strabismus, when we have no movement crossing the midline, then we have to do something like a transposition procedure. Over the years, the transposition procedures have evolved significantly, starting from Hammersheim's, which was using only the half of the muscle, then to O'Connor's, in which full width muscle was used, then Jensen's, in which splitting was done, and the halves of the paralytic muscle and the vertical recti were done. Personally, I am not in favor of Jensen's procedure, because I feel you are transmitting the force of the vertical rectus through a bad courier, because the paralytic muscle is going to convey the force to the sclera, and you are depending on a lax muscle to do the job. It is a waste of the effort done. I would rather do a Nishida's procedure, which directly conveys the vertical rectus force to the sclera. We'll talk about it later. So augmentation of these procedures were also being suggested by Scott Foster in 97 for the full tendon VRT. And then later on, Rosenbaum's group described the posterior fixations on the partial VRT. That means the lateral halves of the superior and the inferior recti were put in order to get the vector force for the lateral rectus, which was paralytic. But since half of the muscle is used and the force is less, you can augment the effect by using the posterior fixation 8 millimeters behind the non-absorbable 5-0 sutures are passed. So this we have found very useful. And as you can see in a more closer view, the inferior rectus and the superior rectus are stitched closer to the lateral rectus, 8 millimeters behind the insertion with the non-absorbable sutures. So they do vectorize the force. And this picture which I had shown earlier of the pre-op, now you can see the post-op after the surgery of partial VRT and Scott Foster augmentation. She is corrected in the primary position, as well as the abduction has improved in significant manner, and the head turn has been corrected. But the problem with this Scott Foster suture is that it does not give you an opportunity to adjust, because you are having a fixed position to the vertical recti. And sometimes you may have an under or over correction. Like this individual, which we had a 6th nerve palsy in the right eye, and after the surgery on the partial VRT with the Scott Foster sutures, you can see there is an over correction. So he is not happy, even though his abduction has improved quite a bit. He's not happy because in the primary position, instead of esotropia, which was giving him diplopia, now he has an exotropia, which gives him diplopia. So these are the problems that we would like to avoid. How can we optimize in these cases? Here we require an adjustable surgery on the vertical recti. David Guyton described, along with Parsa, the adjustable cross-action full width VRT. So what you see here is the superior rectus, the full width muscle has been disinserted and moved in the position of the paralytic muscle. But here you can see there is a cross action. That means the superior rectus is put in the inferior part of the lateral rectus insertion, and the inferior rectus insertion is placed at the superior part of the lateral rectus. Now this gives you a much needed augmentation effect, and you can also adjust these muscles. So this was adjustment along with cross action with full width VRT. And this has been described by David Guyton group, and we have seen that it is quite effective. But since the full width has a risk of anterior segment ischemia, so we use this idea to make it possible on an partial VRT. That means only the lateral halves of the superior and the inferior recti are put on a cross-action adjustable suture, as shown in the schematic diagram, and also the post-op picture at the end of the surgery. You can see on the left-hand side, the superior and the inferior halves are put on the opposite ends of the lateral rectus. Here you can see the lateral rectus, which is paralytic, has not been disinserted or resected. We are saving the blood supply of the lateral rectus, and there is no point in doing a procedure if the vertical recti alone can help. But if you want to augment, you can do application on this lateral rectus. So here I would just show you a video which is showing you the split VRT, initially as conventional as described by Hammelsheim, and then later on as we do in a cross-action manner. So the lateral halves of the superior rectus, you can add a resection effect on these vertical rectus 3.5 millimeter behind the insertion if you pass the sutures. So there will be a resection effect on this vertical recti, and that will augment the effect of the partial VRT. So these 6-0 Weichel sutures have been passed, and then you disinsert the 1/3 or half of the lateral, and then put it at the superior rectus is now here stitched at the upper end of the lateral rectus, and similarly the inferior half will put at the inferior end. So this is the conventional partial VRT that is being shown here, the superior and the inferior halves. But this will, as I said, will have less effect. And Rosenbaum described to use Scott Foster sutures to augment the effect of this. But the other thing that we can do augmentation is by cross-section. Now here what I have done is that the inferior part is coming at the upper end of the lateral rectus, and the superior coming to the lower end. You can see the cross-section. This is a schematic showing you the cross action of the partial VRT. And this helps you in adjusting the vertical recti to your desired effect. It will not only give you a desirable horizontal deviation, but also gives you a control on the post-operative vertical deviation, which might occur in some cases, and sometimes a torsion if they are unequal. So you can easily adjust them and get a more desirable effect. Now, this we had presented in APOS New Orleans 2015, and we had shown that this is a much needed adjustment that we can do. Sometimes we get cases which have been operated elsewhere, but they have partially been corrected by the VRT. You can always explore the partially operated VRT and augment. Like in this case, I had explored and then I had advanced the partial VRTs which was done elsewhere. And this is another option. But if you have an adjustable done, you can do in the same sitting. There are various procedures which have been described. And I would say, like, we have a full dinner plate now. There is a partial tendon VRT. There is a full tendon vertical rectus transposition. We also have now the Hunter's group from Boston describing the superior rectus transposition and the inferior rectus transposition. Mind you, these are full width. Then we have the augmentation by resection. I had described a 3.5 millimeter extra resection effect on the VRT. Or you can have the augmentation effect by the Foster sutures past 8 millimeters from the insertion site. You can also augment by cross section. So these are various possibilities that you can add on to your armamentarium. You can also have an antagonist recessed, the medial rectus in a case of sixth nerve palsy. You can have a recession of this antagonist if required. Some people say that if you have a risk of intersegment ischemia, especially when you're doing a full width VRT, you may not do a recession, but you may do a Botox injection on the antagonist. And you can always do a plication on the paralytic muscle if it has some force in order to give a leash effect. So this is a full plate that you have from Saravana Bhavan. But if you are still wanting something more, that dessert is still there. And that's the Nishida's procedure with the modifications. So modified Nishida's procedure, I mean, this procedure which has been described by the Japanese group describes without disinserting the vertical recti, without splitting the superior, the inferior recti, and using the force to vectorize it. But the interesting part is the effect has been directly communicated to the sclera, unlike the Jensen's procedure in which the force of the vertical recti was partially wasted being through the paralytic lateral recti. So what we do usually as a slight modification is we vectorize the force of the vertical recti, the superior and the inferior rectus. We use non-absorbable sutures past 8 millimeters from the insertion in the superior and the inferior recti. And then we are stitching on the sclera 8 millimeters from the lateral rectus insertion. And this gives us a very good effect on the vertical recti. When you do the Nishida's procedure, you have to be careful about things. For example, I'll show you that you need to, now here, this is a case in which we have done the Nishida's procedure. This is showing you the vertical rectus. We are not going to disinsert, mind you, see. I'm marking it 8 millimeters and non-absorbable 5-0 sutures are being passed in the half of the muscle. You try to save the vessel supply as much as possible. The other thing which you need to do is separate the intermuscular septum on the nasal side so that the vertical rectus is free to be moved or mobilized towards the paralytic muscle. If you don't do that, there may be a compromise in the blood supply in spite of not having disinserted the muscles, and you may have an intersegment ischemia even after a Nishida's procedure. So be careful. So once you have stitched this, and similarly, the other vertical rectus is being explored. 8 millimeters behind marking is done. The 5-0 ethibond sutures are being passed. And then at the sclera, we need to mobilize the vertical recti by having the muscle, sclera, and then again muscles bite in order to have a good effect. And then you can close this. So for the VRTs, for abducens palsy, we have options of adjustable cross-section, partial VRT, which I find is a much more predictable correction. And in addition to the MR recession, which may be done in these cases, the other option which we have at times used is the modified Nishida, along with an adjustable MR recession to give us a more controlled effect. We can also do at times a combination of these. Once when I was doing the procedure in the partial VRT, I had lost one of the splints, and then I could not use the disinsertion of the other side, so I used the inferior rectus half Nishidas. And Yao from China has described combination of this kind also that we can do. On one side, the superior rectus has been disinserted and put, and the other side you can just use a Nishida stitch. Now, when we have fourth nerve palsies, we can do the inferior oblique recessions or the total anterior positionings. But the addition that we have now is the anterior-nasal transposition. Now, in this is a very good procedure, and we do not have to do inferior oblique myectomy ever. And you can have a very good control procedure for even 3+, 4+ inferior oblique overactions, as you can see in this video, in which the inferior oblique is shown. Now, this is the inferior oblique in which we have passed sutures already. The inferior rectus is being hooked, and now it is being brought into the focus. And on the other side, nasal side, the intermuscular septum is snipped. And you can just mobilize the inferior oblique from the temporal half or quadrant to the nasal side. And 2 millimeters from the nasal end, and 2 millimeters nasal and 2 millimeters posterior, a mark is made where I will stitch this muscle. This is a Stager's procedure, or the anterior-nasal transpositioning. And it is a very effective procedure. It can also be adjustable, and you can control the effect that you want either intraoperatively or even after in 2 stages, a double stage adjustable surgery can be done. So this is an additional thing which has come to our use. Coming to the third nerve palsies, we have cases in which the eye may cross the midline, and we can again do the resection or a recession plication procedure, as we talked about. This another case which we have is a very severe 90 prisms exo, in which the resect procedures cannot be of any use because the medial rectus has no effect at all. So such cases, we do a periosteal fixation of the lateral rectus and put the medial rectus on a leash. So this can give the correction. Mind you, if you do a supramaximal recession of lateral rectus, also even 18 to 20 mm of recession we find to be ineffective. So a periosteal fixation of the lateral rectus is a good procedure to use in such a case. This is another case in which we have done a lateral rectus to medial rectus transposition. Now, this is an interesting procedure. A Y-split lateral rectus, we can bring it onto the medial side and insert it to correct the large exotropias which are there, provided the lateral rectus is not very tight. So these cases, we can do a Y-split lateral rectus and improve the severe exotropias. But again, you have to be careful while doing the surgery and not compromise the blood supply by compromising the vortex vein things. And sometimes you can have complications of this. This is another case in which lateral rectus transposition to medial rectus has been done. And this is the schematic which is showing you how the lateral rectus after splitting are brought to the other side. Sometimes we have resorted to a medial periosteal anchoring of the globe, which are very severe exotropias of more than 90 prisms. And after doing a superior lateral rectus recession, we can do an anchoring of the globe on the medial side. This is how this globe can be straightened finally. And this is a cartoon showing that. Sometimes we have third nerve pulses which have aberrant regeneration of the lid. Now, if these cases have the exotropia is not much, then we can just leave it as such. Like in this case, no surgery was done. He was just counseled that his lid can be corrected by him by using the deviations, that the innervations of the aberrant kind. But sometimes there is an exotropia, like in this girl, she has a left third nerve palsy, but the lid gets corrected automatically if she has an adduction innervation. So I chose to operate on the contralateral muscles, and that corrected the exotropia as well as the lids. Now, this is another example of a case in which there was a post-traumatic third nerve palsy with aberrant degeneration. And you can see that after the lateral rectus recession in the contralateral side and MR plication of 15 and 8 millimeters, you can see here the eyes have been straightened as well as the lids have been corrected. So the ptosis gets corrected by using the aberrant force to your advantage. And another interesting case I would just show you here, a 44-year-old female patient was there. She had an exotropia. She was operated earlier, but she was partially corrected. Now, because in the other eye we wanted to operate, but there was another catch here. If you see the 9 gaze positions, in the dextro gaze, she has got an 8 prism basin. In primary position, there is a 16 prism basin, and there is a 35 prism basin in the lateral gaze. Now, it means there is a large incompetence. So if I do a lateral rectus recession of any significant amount, it will induce an esotropia in the dextro gaze. That would not be desirable. So what do? We have to do a controlled procedure which will correct all the 3 gazes. And fortunately, nowadays, what we do is a combo recess procedure on the same muscle. So the resection of the lateral rectus 6 millimeters was done along with a 12 millimeter of recession on the same lateral rectus. And you can see this gives us a more controlled effect, and this gives like a Farden effect on the lateral gaze. So we did not induce an esotropia, and we corrected the primary position as well as corrected the large abduction which was happening and bothering her. So these are the additional things that we can do. Synergistic divergence children, we sometimes find this LR to MR Y split as a boon, because this corrects the aberrant innervation in the right way. And not only the primary position gets corrected, as you can see here, even the adduction will improve after the surgery. This is a synergistic divergence. See here. And after the surgery, he is corrected. So split LR cross-section transposition to the MR is this video which you will see. The lateral rectus is being exposed, and it is split into the upper and the lower halves. 60 Vicryl sutures are passed. The muscles are halves are disinserted. And now we have to maneuver these halves underneath the inferior rectus and underneath the superior rectus. That means between the globe and the muscle. While doing the inferior rectus, there is not a problem because the inferior oblique is on the outer side of the inferior rectus. But when we are mobilizing it on the superior halves, we have to negotiate the superior oblique also. And you may sometimes be better doing a PTSO to help you negotiate these halves very easily. And we have described that you can do a cross section of these halves to give you a much more effect, and that can also be made adjustable. So this is how a cross section LR to MR has been done. And this gives you a very desirable effect of correcting the large exo. And not only the exo, it is also giving you the adduction, because now you have the adduction coming at the right time rather than coming at the wrong time in synergistic divergence. Sometimes we have these partial Thurner palsies with downshoot. Now this we have described as a synergistic innervational downshoot or a SID syndrome. Now on attempted adduction, you'll see the right eye is going down. This is shooting down. Why is it happening? There is an aberrant innervation to the inferior rectus coming during adduction of the right eye. So what we need to do is disinsert the inferior rectus and position it in place of medial rectus, and that would do the job. So this is what has been done. The inferior rectus has been disinserted and placed adjacent to the medial rectus, and you can see that the eye gets corrected as well as the downshoot is also corrected. This is a post-op video of this child, and you can see that the abduction, of course, is not good because we have done the lateral rectus supramaximal recession. But here you can see that the adduction has improved and there is no downshoot. So these cases, with the help of imaging, you can reach to your conclusion which muscles to tackle. The dynamic MRIs or kinetic MRIs done in different gazes can confirm your apprehensions about the aberrant innervations and lead you to the correct muscles to be handled. And what we say is a targeted strabismus surgery. Identify the misinnervation, transpose the misdirected muscle to the correct site, and get the best out of the possibilities that can be there. So I would like to end my talk here. We just need to be a squint intellectual. We have to see what is there on the plate and how we can give the best to the patient so that we can restore the alignment in time so that the binocular vision is not compromised and rather restored, like in this girl. So we need to do this mission altogether of spreading sight and happiness for kids the world across, maintaining the stereopsis and restoring the loss. Thank you for your patient hearing. Thank you all.
Thank you very much, Dr. Pradeep Sharma, for a wonderful talk with so much of explanation and learning which all of us had. A very simple question I have to ask you before others take on. How early would you think of giving a botulinum injection after the paralytic symptoms have started?
Yeah. So botulinum injections we can give, especially in sixth nerve palsies. In third nerve and the fourth nerve, usually they are not good options. But in sixth nerve palsies, those who are the likely candidates, we have to see. Now, one is that if there is an ischemic mononeuropathy, sixth nerve palsy, they would start recovering in 3 weeks' time. And by 3 months, they have recovered to quite a bit. And we usually do not consider them for Botox because they would be recovering on their own. But those cases by 6 weeks have not started to show any recovery and they are bothered about the misalignment. In these cases, we can consider giving Botox to expedite the recovery.
Is there any role of Fresnel prism in paralytic strabismus?
Actually, the paralytic strabismus usually have larger deviations. So the Fresnel prisms are not of much use. But if there is a partial recovery which has happened and there is only a small amount of deviation which is left and you don't want to operate, then there is an option of Fresnel prisms or even considering Botox in these cases again. So that is one. Or let's say you have done a surgery and you have had a partial effect and there is still a residual deviation which is left, then again you can think of giving Fresnel prisms, or you can do an injection Botox in these cases to correct that residual amount to correct the binocular alignment.
On to you, Dr. Murli. Your questions?
Yeah, Dr. Spillman, any comments, and then I'll ask. Dr. Spillman, any comments or?
He's muted.
You're muted, Dr. Spillman.
Yeah.
Tell him.
Yeah, he got it.
Well, ocular motor palsies is a most difficult field of strabismus surgery. It's difficult to assess our result because we won't have 100%. Thing will not be as before. We can't cure a palsy, so we have to accept some residual palsy, some residual squint in some direction of gaze, and an improvement of 50% of a large palsy is already a good result. And any of the techniques used and described that are a wide variety of techniques, all of them will make the patient better. And what is difficult is to find the best one to be used in the case. And it requires a lot of time for examination of the patient, especially when there is synkinesis. And I can remember patients for whom I spend 20 minutes or half an hour to think about what I would do, especially in things with complex synkinesis. And it's one of the most interesting intellectual work for us as strabismologists. It's also very funny if we think and try to imagine. And in fact, I really enjoyed some of the cases Pradeep showed to us, the one with synergistic divergence and complex things like this. And at least we have fun in doing so. And that's what we are doing a great job for the patient, and for us also it's intellectually challenging. So I don't have my opinion does not count because each patient is different. As a surgeon, what I thing is that the simpler, the better. I mean, an Ishida procedure is very simple to implement. Just put your suture, move the muscle, and in that it has an intellectual value. It saves time for us, for the patient. It seems not to be so invasive. I'm not sure it's better because there are pros and cons in each technique, but any technique which looks simple seems better for me than any complicated technique. For this, I'm suspicious about adjustable transpositions, because in transposition there is always something that you cannot control, that is scarring. Everybody knows that if you go back on the surgical field, you will find adherences and leashes and anything, and reoperating transposed muscle is difficult. So there are scarring phenomena that will make the final result different from the result the day after surgery. And I'm not sure that adjustable transposition is always a good idea, because there are things that you cannot control in complex transposition. That's a personal view. I don't have a personal experience in adjustable transposition. I thought a lot about this because it gives interest for me to think about it. But for the reasons of scarring, I'm still suspicious about this.
Dr. Murli?
Yeah, we have one audience question. That is, have you ever operated a squint, a paralytic squint, for purely cosmetic purpose? What I understand is that if the patient has a traumatic, just an example, has a traumatic optic neuropathy and a traumatic third nerve palsy which is not recovered, the vision in the eyes are really poor. Have you operated that, and what percentage of paralytic strabismus practice would that constitute? Let's say a patient has not recovered from traumatic optic neuropathy, or because of some other reason, let's say retinal detachment or corneal injury, the patient is not getting good vision. At the same time, he has a cosmetically deforming paralytic strabismus, which could be sixth or third nerve palsy. Would you operate? And what percentage of patients in your practice would that constitute?
Yeah. So I think one thing is that there are patients who may have traumatic optic neuropathy in one eye. They may not complain of diplopia, but in these cases, they do have a head posture because the eyes are fixed in an abnormal position. So there is an indication to correct the paralytic strabismus, even though the vision is poor in the other eye. So that is one indication. Another thing is that one of the cases which I had shown, that sixth nerve palsy, which was having a bitemporal hemianopia. Now, because of the bitemporal hemianopia, at the time of presentation, there was no diplopia, but there was a face turn. There was basically a deviation because the eyes were not able to move. So he was keen to get it corrected. And here there was a risk that if you do a correction and if you do a little bit over correction, the eye is going to an exotropia of even a 5 prisms or 10 prisms, he would be having diplopia, because then they come out of the scotomatous area. So there was a catch. So that is why we chose to do an adjustable procedure on the medial rectus. And it was good that we could do it so that the eyes are now straight to the optimal requirement. So I think these two situations, one is that they may be having a poor vision in one eye, they don't have diplopia. So you may do a surgery to correct their alignments so that the head is straight, the deviations are corrected in the primary position.
This bilateral acquired fourth nerve palsy is a difficult situation. So, because many times they present with torsional diplopia in down gaze, and they may have a small chin down. So how would you?
That's a very good question. That we have a bilateral fourth nerve palsy. Usually, the vertical deviation is not much because one is neutralized by the other eye's palsy, but they have an additional, added up torsional component. So they have usually large extorsion, which they are bothered about, and especially in looking down. So we have had some situations when there were a lot of trouble that they could not work, although the deviations did not appear so much on looking at it, but this extorsion needs to be corrected more correctly. And in these cases, an Harada-Ito procedure is what I would do. So what I do in such cases is a Harada-Ito procedure on one side and the adjustable Harada-Ito on the other side to correct the extorsion to the desirable amount.
Okay.
Well,
Yeah.
in bilateral false nail palsy, I always tell the patient that at least 2 operations will be needed, and sometimes 3. And because we in my hands, I never get satisfactory results in all direction of gazes, and usually even you are very happy with results in primary position, they still have cyclodiplopia and horizontal esotropia in down gaze, and probably most of them will need a restoration of the inferior rectus with a shift of the insertion. It's very useful to improve down gaze, to shift the insertion of the inferior rectus.
Dr. Hamid, do you have any question?
Yes. Does vertical rectus transposition cause torsion? Do they induce torsion? How do we manage if there is a significant torsion post vertical rectus transposition?
For which cases you're talking about? The nystagmus cases that vertical rectus has been used? Or what?
In the paralytic strabismus.
Yeah, in paralytic strabismus, when we are doing the PVRTs, we are careful. I mean, in principle, generally my approach is to do a balanced partial VRT. That means I would be balancing the superior and the inferior recti to prevent any vertical deviation post-operatively as well as a torsional effect. But people who are routinely doing SRTs like the Hunter's group, they claim that the torsion is not much. But I see that at least the vertical deviations can be seen even in some of their presentations in the pictures. I can see that there is a vertical deviation of at least 5 to 8 prisms, which happens when you do only one of the vertical rectus. So one has to be careful. And if the vertical deviation is bothering you, you may have to revisit, or you can do then a balancing effect on the other muscle. Like if you have done an SRT and you got a torsion and a vertical deviation, now you can do a inferior rectus Nishida procedure to correct that. So you may have to balance it. I prefer usually to do a balanced approach of working on both the superior and the inferior recti equally, so that I do not create an unbalanced situation.
And there's one more question. What is the role of inferior oblique myectomy and superior oblique tenotomy in a LR to MR transposition? In a case of a third nerve palsy, does it give more correction? Does it make the procedure more easier to do?
So when we are having this lateral rectus Y split transferred to the medial side, as I said, usually the inferior oblique doesn't come in our way. It's not usually creating any problem because the inferior oblique is passing underneath the inferior rectus on the outer side of the inferior rectus, and we are working on the underside of the inferior rectus, so it doesn't really create a problem. But yes, superior oblique is going to be interfering in your mobilization of the lateral rectus to the medial side. And usually these third nerve palsies in which we are operating, we will also have a superior oblique overaction, which is causing a hypertropia. So it may be good to do a PTSO, a posterior tenectomy of the superior oblique, which does the tenotomy partially of the posterior part and makes it much easier to mobilize the lateral rectus underneath the both superior oblique and the superior rectus. So you can do a partial tenectomy of the superior oblique in cases of the lateral rectus to medial rectus shift. Although I think from Turkey, Dr. Gokejit, Birsin Gokejit has described that even if she has not done a superior oblique PTSO, there may be a little bit of kinking of the superior oblique, but the effect still comes. And that is also true.
And there's one more question. If you plan to do a resect procedure in a 6th nerve paralysis in which there's some function of the LR muscle, how much should one do recession and resection? So like more than what we normally do, how much do we do? Like And
would
is there
more than
does the
12
procedure
yeah.
does
In
the
that
procedure
case,
last long?
one is that we'll have to go by the force reduction test. So intraoperatively, you will see the force reduction test of the antagonist. If there has been a long-standing paralytic strabismus, the contractures and the force reduction tests are going to be more permanent. So you would have to do a larger amount of recession than normally you would do in concomitant strabismus. These are much stronger muscles now, antagonists. So for example, in third nerve palsies, the lateral rectus, we may have to do something like 18 or even 22 millimeters of recession from the insertion side. That means add this to 7 millimeters of the limbus, it would be 25 or 30 millimeters from the limbus, a lateral rectus recession. And that is why the other alternative is to do a lateral rectus periosteal fixation, because they are such strong lateral recti in third nerve palsies that even after doing a supramaximal recessions of 12 or 15 or 18, they would be having an exotropias. So you have to do much larger amounts, and you will have to do an intraoperative force reduction test to ensure that the force reduction test is free at the end of your surgery.
Thank you.
Definitely.
We
you.
shall now, any other question, or shall I go on to the next
That's
talk?
it. That's it. Done now. No question.
Dr. Muralidhar is our next speaker and is a consultant glaucoma and neuro-ophthalmology, pediatric and neuro-ophthalmology at the Eye Foundation, Coimbatore. After a fellowship in RP Center and Murray's Eye Centers, he has been with us and an extremely patient and one of the most popular surgeons of our hospital. He has always had keen interest in dealing with the refractory glaucomas and developing safe surgical systems too. He has conducted innumerable surgical instruction courses and has had many publications in peer-reviewed journals. And he would be talking on a simplified approach to managing pattern strabismus.
Thank you so much, madam. So I'll be talking on managing the pattern strabismus, primarily about the A and B pattern strabismus. Pattern strabismus constitute roughly 12.5 to 50% of our practice in horizontal deviation. I shall primarily be talking about A pattern and B pattern strabismus, but you also have this lambda, Y, diamond, T pattern, and arrow pattern. So the deviation is described by the primary position deviation. This patient has an esotropia. If you notice, the esotropia increases in up gaze and reduces in down gaze. So this is like an alphabet A. So therefore, this patient has an A pattern esotropia. So this from Pradeep Sharma sir's book. This is the horizontal school of thought that was propounded to explain how pattern strabismus occurs. LRs are more effective in up gaze and medial recti are more effective in down gaze. So an overacting LR would cause a V pattern exotropia. An overacting MR would cause a V pattern esotropia. Likewise, underaction of the horizontal recti were used to explain A pattern strabismus. Then there was the cyclovertical school of thought, which said that inferior obliques and inferior rectus overact together. When inferior oblique and inferior recti overact together, inferior oblique overacts in up gaze, inferior recti causes adduction in down gaze, and these together would cause a V pattern. Likewise, superior oblique would cause more divergence in down gaze and superior recti more adduction in up gaze, and this would cause a pattern strabismus. So the role of pulleys has recently been propounded by Dr. Deemer and is thought to be the primary mechanism for pattern strabismus. And these are the other theories that have also been propounded. So the significance of identifying an A or B pattern is that these are associated with potentially low level of binocularity. If you fail to recognize and treat these patterns, you treat only for the horizontal deviation, you end up with a very bad result. Sometimes these can cause a head posture. And the criteria for diagnosis, as I already said, the deviation in primary position is what categorizes it as ESO or exotropia. You measure in 25-degree up gaze and 35-degree down gaze. A 10 prism diopter is taken as a significant A pattern, and a 15 prism diopter is taken as a significant B pattern. So this patient I've already discussed. This patient has an A pattern esotropia. This patient has an esotropia in primary position. The ESO is less in up gaze and more in down gaze. So this patient has a B pattern esotropia, ESO in primary position. So these two patients have exotropia in primary position. The first one has more exotropia in up gaze, less in down gaze, suggestive of a V alphabet pattern. So this patient has a V exotropia. This patient has more exotropia in down gaze, less in up gaze, So this patient has a pattern exotropia. So for workup, the workup would be similar, would follow all the steps of a standard strabismus workup. That is, you would do a history, you would do a vision, cycloplegic refraction, amblyopia management, test for binocularity. Here is what is different. In addition to measuring in different gazes, you would recognize and grade oblique dysfunction. Then there are these other factors, and then you have to do a comprehensive anterior and posterior segment evaluation and systemic and neurological wherever it is required. So this patient has a pattern exotropia, more exo and down gaze. So you measure in primary position, up and down gaze, check for any lateral incompetence, and grade the oblique overaction. About the oblique overaction grading, I shall be mentioning it shortly. So this patient has a V pattern exotropia, more exo in up gaze, less in down gaze. So in primary position, he or she measures 35 prism diopters. In up gaze, it is 50, and in down gaze, it is 12. So this patient has a bilateral inferior oblique overaction of 3+ also, which needs to be factored in for surgery. So if I were to give you an algorithm, so for V pattern, you grade the inferior oblique overaction. If the inferior oblique overaction is present, you do inferior oblique overaction and surgery based on primary position deviation. If there is no inferior oblique overaction, you would do a shift or a slant. For A pattern, if there is a superior oblique overaction, you would do an appropriate superior oblique weakening procedure and surgery based on primary position deviation. About the correction, I'll mention shortly. And if there is no superior oblique overaction, you can do a shifting or slant. I would request the panelists to correct me if I'm wrong. You do not make any adjustment for the amount of V or A pattern. So a particular patient may have 30 or 40 presence of V pattern, another may have only 15 to 20. The surgery would be similar because generally the surgery is considered as auto-adjusting. The same for A pattern. And now I'll talk about grading oblique dysfunction. This is again from Sir's book. So you draw a horizontal line bisecting the pupil of the abducted eye, and you note by what degrees the pupil in the adducted eye is elevated. Grade it as 1, 2, 3, or 4. You can also mention the number of millimeters the pupil is above. The pupil of the adducted eye is above the horizontal line. So this is very important. Note the R by L in down gaze. This patient, R by L in left gaze. So, and when the patient goes to levo elevation, you note an inferior oblique overaction of 2+ based on the grading that I have already mentioned. So this patient has a left inferior, same patient, left inferior oblique overaction of 2+ and a right inferior oblique overaction of 2+. So you can have an asymmetric inferior oblique overaction where you do a asymmetric procedure. This patient has a left inferior oblique overaction of 1+ and a right inferior oblique overaction of 4+. So this patient has bilateral inferior oblique overaction of 4+, the grading which I have already mentioned. So this is a very small superior oblique overaction for a pattern patient with A pattern strabismus. This patient has a superior. These are just examples which are based on the grading system that I have already described, just for illustration for the audience. So the right superior oblique overaction is 3+, and the left is also 3+, and this would constitute a 4+ superior oblique overaction. So just to show an upshoot and downshoot because of a tight lateral rectus. So this patient did not have a V pattern when we measured her. Even though this appears to be a V pattern, on measurement there was no difference. Note that this patient has an upshoot. There is no R by L or L by R or dextro or levo version. But if you note, there is an upshoot on up and down gaze. So we did 3 rectus surgery, bilateral LR recession and left medial rectus resection. And postoperatively, we got a good correction of the primary position. In addition, if you see, the upshoot or the so-called inferior oblique overaction is also gone. So for V patterns with inferior oblique overaction, the horizontal surgery is guided by the primary position deviation. Do not make any adjustment because inferior oblique surgery does not influence the primary position deviation. So this is my personal preference. For 2+, I would do Finks. For 3+, I have now moved on to apt and call. And for 4+, IO at the center of inferior rectus. If you are doing it primarily for a dissociated vertical deviation, you have to incorporate some form of an anteroposition. So maximal recession that you can do is 12 millimeter. If you want for 4+ overaction, you could add a little anteroposition. You can also do a nasal transposition. You could bunch up the muscle. If you remove a segment of the inferior oblique, then you are effectively weakening the inferior oblique because inferior oblique doesn't have a tendon. This is the apt and call grading of recession that I've taken from Rosenbaum's book. This is the relevant anatomy that you need to know. Note that the optic nerve is in proximity to the posterior end of the inferior oblique, and so is the vortex vein. And this is the hooking of the inferior oblique muscle. So I've used a phonics incision here. So after making a phonics incision and buttonholing the tenons, you can see the anterior border of the inferior oblique. You use two Stevens hooks to get the inferior oblique out, and this is the posterior triangle that signifies the posterior border of the inferior oblique. So I have introduced a Chavas hook now, and I dissect out the intermuscular septa. If you don't dissect the intermuscular septa, you can the inferior oblique can continue to transmit force, and your surgery would become weak, would become ineffective essentially. So having done that, you don't have to pre-place sutures. I like to do so because I want to maintain the width of the inferior oblique, but the inferior oblique is not going to slip because of its attachment to the Lockwood's ligament and the inferior rectus. It's not going to slip, so you can cut and pass sutures also. So these are the schema for recession, the relevant anatomy, and this is from first book again, modified iliac nankin sphinx and total antral positioning. I would recommend you to this book. And this is the modified iliac nankins. This is the lateral rectus. This is the inferior rectus. You pass one bite, 0.5 millimeter lateral to the true insertion of the inferior rectus, and the second bite 5 millimeter behind. And this is Park's recession. First bite 0.5 millimeter lateral to the inferior rectus insertion. I'm sorry, this is antral positioning. And the second bite effectively bunches up the muscle. Sorry, my connection is stable. This is the schema for Park's recession. The IR is hooked. And then you identify the ski Park's point, which is 2 millimeters lateral to the IR insertion and 3 millimeters behind.
We can't hear you.
Can you hear me, madam?
Yeah.
Yeah, this is myectomy, very old video. Nowadays we don't do it. You just have to clamp the two ends, because the primary reason why we don't do it is, even though there are advantages that claim that it is auto-adjusting, effectively when you go in for resurgeries, you get nothing out of it. I mean, sometimes you may fail to trace the inferior oblique. Sometimes the inferior oblique may attach over a wide insertion. So to prevent attaching over a wide insertion, you clamp it and cauterize the ends. So this is inferior oblique center of inferior rectus. This is done for 4+ inferior oblique overaction. So the inferior rectus is prolapsed. Pradeep Sharma sir had shown you that you can shift it nasally. So what I do for 4+ is, I mean, recently I've also started doing the nasal antral positioning. Very good if there is persistent overaction after a previous recession. And so this is an antral positioning where you do it at the center of the inferior rectus. So the more nasal you go, the less likely you are to cause a anti-elevation syndrome. So this patient has bilateral inferior. This is a preoperative photograph. Bilateral inferior oblique overaction of 2+ to 3+. And this is after surgery. The V pattern is addressed. Note, this is the V pattern, and the V pattern has collapsed. So these are the complications of inferior oblique surgery that I would like you to remember. That is, injury to both should never happen. It's very difficult to identify and ligate. You can have fat prolapse, and the others fortunately are rare and generally don't happen, and usually reverse with time. So now we'll go to A pattern with superior oblique overaction. Here for exotropias, you need to reduce the target angle by 5 to 10 prism diopters because superior oblique has some kind of an abducting action. So if you weaken it, again, I request the panelists to correct me if wrong. I generally reduce the target angle by 5 to 10 prism diopters for superior oblique. So my personal preference is 1 plus don't do. For 2 plus, I would do a posterior tinectomy of the superior oblique. For 3 plus and 4 plus, I would either do a PTSO with frenulum lysis or a nasal tenotomy. Again, for Brown syndrome, you would do a spacer. So this is again from Sir's book. You would remove a 10 millimeter segment, posterior 7, 8, leave only anterior 1 millimeter. That's what I do these days. And superior rectus is hooked. And the area underneath is retracted. Superior oblique is directly beneath it. And you identify the silvery fibers of the superior oblique. And make sure you hook the posterior most superior oblique. If you have not hooked the posterior most, your surgery may just go ineffective. So superior oblique has to be hooked under direct vision, no fishing around here. So once you do that, you use a blade breaker to split the anterior 1 millimeter and the posterior this thing and remove a 10 millimeter segment of the posterior. So this is the anterior segment, this is the posterior part, and I would cut the posterior part, not 7, 8, but I would remove whatever is left other than the anterior 1 millimeter. So this is for Brown syndrome. I'm just showing you the approach as to how to go from temporal to nasal. For an expander, I would not focus on the expander because that is, even though Brown syndrome causes a Y pattern strabismus, that's not the talk for today. So after prolapsing the superior rectus out, the silvery fibers of the superior oblique are seen on the nasal border. They are seen and hooked under direct vision. So once they are hooked under direct vision, you can do a procedure of your choice. And this is another way to hook the superior oblique on the nasal side, which you can use for a nasal tenotomy or so you use a Stevens hook, go 1 centimeter behind and come out, whatever you bring out of the superior oblique. Somewhat blind procedure, but I have found it very good for nasal tenotomies. Rarely I end up use it for 3 plus and 4 plus, and rarely end up with anything. Now I have used it even for Z tendon lengthening. Also, I use this approach to hook it on the nasal side. So you go 1 centimeter behind with a Stevens hook, and whatever you come out with is superior oblique tendon. And this is the superior oblique tendon on the nasal side. And you can do whatever procedure that you want with it, either remove a part of it or. So these are the complications of superior oblique surgery. You can have residual overaction, which I find the most common thing. You can have a torsional diplopia. Fortunately rare because pattern strabismus is associated with a potentially low binocularity. You can injure the SR or the LPS. You can minimize this by meticulous surgical technique. Overcorrections, fortunately, are very rare because we never do a complete tinectomy of the superior oblique. If you do a complete tinectomy, the incidence of overcorrection is 75%. So we never do a complete tinectomy. So these are some of my patients. And this patient has a bilateral superior oblique overaction. I did a nasal tenotomy only. It was not a complete tinectomy, and this is the effect that you get after surgery. This was the technique that I learned at New York Eye and Ear Infirmary. And this patient has a bilateral superior oblique overaction. This is before, and this is after. The one on the left side is before the surgery, and on the right side is after the surgery. And this is the A pattern, which has successfully collapsed after surgery. And this patient has exotropia and had a severe superior oblique overaction of 4 plus, greatly relieved, and the primary position also is much better after surgery. So for patterns without oblique dysfunction, you can do a shift or a slant. Some people have questioned the efficacy of slant and also the direction in which it should be done. And MR is shifted to the apex of the alphabet and LR towards base. And this is the theory. This is taken from Pretorius. So if you shift the rectus muscle down, then the patient looks the lever arm is much more distorted, so it is weaker. So you shift the muscles in the direction you want to weaken it. When the patient looks up, the direction of the muscle is normalized and it regains its strength. So for slant, for slant, you recess the pole that is opposite to where you want weakening. But again, the direction of slant is controversial. Both directions have been shown to have effect, and some people have actually questioned whether slants are really effective or not. So this is how you do a upshift of the muscle. So you mark it concentrically and measure perpendicularly. Sorry, for some reason my video is playing very slow. I'll see if I can go out and I'll just try to play it from outside. I'm sorry, because it's an important video. Just give me 1 second. Okay, I'm sorry, I'm not able to get it. So yeah, I'll try to fast forward and see. And the marking is perpendicular, to where you have marked the shift. And once you have done it, this is how a shifted recession looks like. As for a shifting resection, so once you have cut the muscle, cut the stump of the muscle, you mark the shift distance, 5 mm downshift, marked on the insertion. You pass the suture, and the next one is marked concentrically. So once you have tied the sutures, this rectus muscle is downshifted. Okay, for a slant, just for the purpose. So upper end is marked 5 mm. So let's say you have to do a lateral rectus recession for a V pattern. Upper end would be marked 5 mm and lower end would be marked 7 mm. You can do it on both sides. I just did it for the purpose of recording, but frankly, I don't believe much in slants. And some people have actually questioned whether they are really effective or not. So the upper end is recessed 5 mm and the lower end is recessed 7 mm. The center probably by 6 mm, and the central recession is decided by the primary position. So these are some of my patients. This patient has a pattern esotropia, note the iso more in upgaze, and yeah, after surgery, this is how the patient looks like with correction. So for vertical recti, you rarely use it to correct pattern strabismus. But when you do a bilateral inferior rectus recession, to avoid a consecutive A pattern, you would shift it nasally. And it can also be used for paradoxical patterns as well. So this patient has a bilateral superior oblique palsy, acquired traumatic, and had an arrow pattern esotropia. So we did a bilateral inferior rectus recession of 6 mm and didn't do any shifting. And this was the collapse of the arrow pattern that we got. The patient still had some torsional diplopia on looking more than 10 to 15 degree down gaze, but was much improved. And yeah, the outcome of surgery is that generally the belief is that there is less postoperative drift after surgery for pattern strabismus, and possibly because only mechanical factors are involved, and therefore better results are obtained, better anatomical result, better motor success result is obtained if there is an oblique dysfunction. And so there has been a lot of talk on how police would influence the management of pattern strabismus, but this is limited by the availability of dynamic MRI. And so currently we continue to do what we have been doing, and my acknowledgement. And thank you so much.
Thank you very much, Dr. Murli. I do hope we have good questions following your talk. One very simple question. If you have missed the A or V pattern, then I'm sure it will have a very serious impact on your surgical result, I'm sure, no?
Yes, madam. If you miss a pattern and you operate just based on the primary position deviation, you are likely to have a very compromised result. So, as a routine, all these patients with horizontal deviation, we measure them in up and down gaze on a routine basis.
Is there anything like a pseudo A or V pattern?
Yes, a pseudo A or V pattern has been described. Sometimes these patients can have can have a pseudo medial rectus overaction because of a high AC by A ratio. And because medial rectus is more effective in down gaze, so you may actually end up with a pseudo A or B.
The pseudo V's can be seen with the commonly with the IDS patients because they fuse in the down gaze easily and they break up when you are just doing a cursory look by spanning from down to up. You may feel there is a V pattern, but if you measure them in the up and the down gazes, you find that the exo is the same. Then it is called a pseudo V pattern.
Any questions, Dr. Pradeep Sharma? You want to bring out any other point?
I think Dr. Murli was suggesting, or rather asking, that what should be done if if there is whether only the inferior obliques or only the shifting should be done. So we mostly what we find is for the inferior obliques when we are operating, the effect is about 25 prism diopter between the up and the down positions. The same is true for cases in which we are doing the vertical shifting of horizontal recti. The correction of V is about 25 prisms by the shifting alone. But in some cases, when we have a pre-operative V pattern of 35 or more, in those cases, I have seen that we have to combine both. So the inferior oblique surgery is done, but that would not fully correct the V pattern. And I usually combine it with a vertical shift of the lateral rectus also. So like in a V exo of 35 prism diopters, I would do a bilateral recession with lateral rectus shifted up 5 millimeters and bilateral inferior obliques because they are also overacting. The other thing which you were asking about was the whether we need to make any correction in the horizontal deviations. So you're right that when we are handling the inferior obliques, we do not make any correction whether we are doing inferior obliques or not. We will go precisely by the horizontal measurements in the primary position. The same is true for superior obliques, mostly because when we are doing controlled procedures. I think what Jampolsky had described 25, 30 years back, that superior oblique surgeries have a 10 prisms of ESO shift. He was talking about the superior oblique full tenotomies, which was being done at that time. But nowadays, since we are doing PTSOs in majority of the cases, we do not see any horizontal ESO shift because of the superior oblique partial tenotomies or tenectomies. But if you do a full tenectomy, then probably you may have a ESO shift.
Any questions, Dr. Hamid?
There's one question actually. If it, can you hear me? If a patient is having a V pattern, but minimal or no inferior oblique overaction, but on fundus you see a significant extorsion, do you try to touch the inferior obliques or just do the shifting?
Yeah, that's a very important question. This comes into play more with asymmetric inferior oblique overactions. So if you have inferior oblique overaction primarily on one side and the other side you do extraction, it was suggested that you can do a mild procedure on the other side. It's missed inferior oblique overaction. That's what it was said. And it has been published also that you can do a Z tenotomy on the inferior oblique. So yes, I would take a torsion is significant, extraction is significant only if there is an asymmetric, because normally V pattern is associated with an element of extraction. Because the way the globe shifts. So there is some amount of extraction even otherwise. So, but if there is an asymmetric inferior oblique overaction and one side is let's say 3 plus and the other side hardly 1 plus, but on that side also you have an extraction, I would possibly do an asymmetric inferior oblique procedure. Any comments, Pradeep Sharma sir or Dr. Alan Spielman?
For asymmetric inferior oblique overactions, we would be doing inferior oblique weakening also asymmetrically. For example, on one side you have a 3 plus or 4 plus inferior oblique overaction. I would choose to do an anterior nasal transposition of the inferior oblique on that side, and the other side which is having only 1 plus or 2 plus, then I would do either a modified iliac nankin if it is a 2 plus, And if it's just 1+ on one side, I might do a sphinx recession on one side. So you may choose to do an asymmetric procedure. What we believe is that inferior obliques also need to be done in a tailored approach. The self-correction thing, I do not really believe. I see that it does have an effect of overaction. Depending on how much overaction is there, you have to tailor your surgery according to that.
But would you operate just based on the torsion alone if clinically there is no over elevation and adduction? As Hamid was asking, possibly.
I mean, what Dr. Hamid was asking, I really feel that if you have an extorsion, it is definitely going to have an over elevation also. The reverse may be true, that you may have a feeling that there is a V pattern, but there is no extorsion. It would imply that there is no inferior oblique overaction, because in inferior oblique overaction, if it is there, it's primarily an extorter. It may not have much of vertical shift, but definitely it will have an extortion effect in the up positions. So in up gaze, if you have an extorsion, it is definitely indicative of an inferior oblique overaction.
Dr. Spellman, any comments on?
Okay. I often look at the slant of the lid fissure, which is associated with A and V pattern. At least in my country, in Europe, in Caucasian people, A pattern is often associated with the slant of the palpebral fissure like this, and V pattern with slanted fissure like this. It means that there is a cyclotorsion not only of the eye, but also of all the components of the orbit of the muscle, and everything is, the orbit is torted. Another comment is about V pattern without inferior oblique overaction. So we wonder whether there is extorsion or not. And in some cases, I feel helpful to have pictures of the fundus to measure objective torsion. I do not do it routinely for all the patients because usually we have cyclotorsion, we know this, but in some patients it can be useful. Another comment is about not A or V pattern, but Y patterns. And sometimes they are straight in down gaze, in primary position, and in up gaze, they have very huge exotropia. When I say very, very huge, sometimes 30, 40, 50 diopters. And I wonder, but I don't know if I'm right. I always wonder whether it's a kind of synkinesis, a kind of CCDD with synergistic divergence in up gaze. And we can have the same reasoning about A pattern and exotropia in down gaze. Maybe it's synergistic without extorsion, but just innervational. I don't have the answer. That's just a thought about it.
We have a few more questions for the panelists. And that is, Dr. Spearman, you had mentioned using non-absorbable sutures for the inferior rectus. So do you do it even for conventional surgeries, or would you do it only for adjustable inferior rectus recessions, the use of non-absorbable sutures? And what suture do you use?
I'm sorry, I didn't understand.
No, you had mentioned using non-absorbable sutures for the inferior rectus recession.
Yes.
So would you use it for conventional surgeries, or do you use it only for adjustable strabismus surgeries? And
I use it only for adjustable sutures. But sometimes if I recess without adjustable suture, I use a Vicryl 5-0, not 6-0, to be absorbed, which is absorbable, but which will last longer than 6-0. And sometimes I double the scleral point. I do it twice in the temporal edge and twice in the nasal edge to make sure that the inferior rectus is will be strongly adherent to the sclera. For adjustable suture, I use nylon 5-0. In the past, I use merciture. I don't know if the word is correct, but it leads to inflammation and granuloma around this suture. So I use nylon. It's not perfect because sometimes it itches the lid, and I have to cut the nose 2 or 3 months later, but I wait at least 2 months before cutting the nose because I'm afraid about late overcorrection.
Have you operated on any patient with acquired periodic alternating nystagmus that is not? So occasionally we see these patients with acquired periodic alternating nystagmus that don't respond adequately to medication. So have you operated on any patients with an acquired periodic alternating nystagmus?
So if I understand you ask if I have operation acquired periodic alternating nystagmus. That's a question?
Yes.
Yes, I did it a few times, especially in adult patients with oscillopsia, because acquired nystagmus leads to oscillopsia, and it's very disabling. I did a large recession of the 4 horizontal muscles. The nystagmus didn't disappear, but the oscillopsia was less disabling for sure. It even disappeared in daily life, except when people were tired. But okay, it had really a good effect on oscillopsia and also on the alternating head turn. So I can recommend doing so.
Okay, I have one more question. That is for the panelists. What is your transposition procedure of choice in sixth nerve palsy, and how do you choose between them? Like Pradeep Sharma sir showed Nishida's procedure, Hamelshim's procedure, and adjustable VRT. So how do you decide which procedure is to be done for which?
Well, to be honest, it's the question of feeling, and I change my mind. Sometimes I will do Hummelsheim. The next time I will try Nishida. I don't. There is no procedure of choice. Really, that's what I think.
Like Sharma sir.
Well, the question is whether to recess the medial rectus or not, and how much, and with adjustable suture or not. The main risk is anterior segment ischemia. If you go on the superior and in the inferior, even if you take care, you don't know what will happen with the vessel. Maybe when you stretch the muscle, the ciliary vessel will suffer during surgery or after scarring. So the only risk is anterior segment ischemia. So I will decide. My thoughts are about recessing the medial rectus or not, and how much. In one step or in another step, everything is possible. Some advocate botulinum toxin instead of recessing the medial rectus, so that the transposition will work better, and that scarring will do in the best position. Really, I'm very humble about this. I don't have, there is no dogma, you know, and I think everything will work.
Any other
Likewise
question?
for complete non-recovering third nerve palsy, Which one would you choose, like LR to MR or LR periosteal fixation with MR resection or globe fixation? Like, how do you choose between?
I can't hear you. Are you speaking to me?
Yeah. I'm speaking to both of you, actually, Dr. Pradeep Sharma sir, and to you. My question was likewise between for complete non-recovering third nerve palsy.
Yeah.
How do you choose which procedure to do, like an LRDI periosteal fixation or LR to MR or globe fixation periosteal anchoring? How do you choose between them?
Yes, lately I shifted to transposition of the lateral rectus to the nasal, to the medial rectus. It's not difficult to do so. It's fun. The main difficulty is the superior oblique, and so you have to move to shift the lateral rectus under the superior oblique. In fact, with a hook, I don't know the word of the name of the hook, but with a hole where you can pull the lateral half, the lateral rectus half. It's easy to, it's not so difficult to deal with the superior oblique. Up for now, I didn't have any severe complication, retinal or optic disc complication, but I know we take the risk of uveal effusion or papillitis, disc edema, and I always fear to have someday this complication. I suppose when I will have complication, I will change my habits, but now my preferred choice is this transposition, but I may change in the future as soon as I will have complications. Maybe next time I will try to put the muscle on the orbital bone, but I don't have the experience yet of this technique. But for sure it will work.
Any comments, Pradeep Sharma?
Does anyone among you had the complication, severe complication with the shift of the lateral rectus to the medial rectus? Yes. Yeah. Can you describe?
We have one case of uveal effusion syndrome, and we have published it. Unfortunately, we did have one case of that girl. She developed uveal effusion syndrome. It was very, very horrifying, because in the first week, when you see 2-3 days later that the eye is getting aqueous flare coming in, and then the inflammation is there. And what I did was to disinsert the sutures, release the sutures of the lateral rectus, which we had put, and that relieved. So the uveal effusion syndrome finally got relieved with the help of disinsertion of these sutures plus steroids, which was given for 2 weeks. So she recovered her vision. But yeah, it can happen. So I think there is a possibility of compromising the blood supply in the posterior part, maybe in the vortex veins, because there are 4 vortex veins that it has to be coming and encountering. So if there is a possibility of compressing, there is really, it's a possibility. So you have to be very, very careful when we are doing this splitting procedure. It should be large, long enough, more than 25 millimeters. Because if you have not split the lateral rectus enough, there is a possibility of strangulating the these short posterior ciliary vessels around the optic nerve where it is coming on the other side. So this is something which you have to keep in mind. The same is true for the anterior segment ischemias. Even with the Nishidas, I just got a call from Malaysia. One of the doctors, Dr. I think Hu Shu, he said that he did modified Nishida's procedure, and he developed, in that case, an anterior segment ischemia. So that is a possibility. So you have to be very careful when you deal with these drastic procedures. You need to mobilize the muscles carefully. They are very good procedures, but you need to be extra diligent in seeing that there is full mobility is ensured. But otherwise, in an odd case, you may get complications. Yes. Regarding the choice of surgery that you'll do, it will depend upon certain factors. Now, for example, if you have a tight lateral rectus, in such a case, we wouldn't like to do a Y-split lateral rectus transpose if it's very tight. If it is minimal, mild tight, then we may still do the lateral rectus Y-split and bring it to the medial side. But in a very tight lateral rectus, the choice would be to do a LR periosteal fixation, and that along with the medial rectus plication may work in some cases. If you have some cases which do not correct the exotropia still, you may do a periosteal anchoring of the globe in addition to the lateral rectus periosteal fixation. That works in majority of the cases, even with very severe exotropias. So you can choose depending upon the case. I mean, if there is a lateral rectus tightness, one should avoid doing the lateral rectus Y-split procedure on the medial side. Similarly, I mean, if you have, as I said, different types I had shown, if there is an aberrant regeneration, you may do a contralateral eye surgery, LR, MR on the other side, because that will give you much more effect on the lids also. And if the eye is crossing the midline, you may get away with the LR recession and the medial rectus plication. But whenever possible, avoid doing resections, because you will be unnecessarily compromising the blood supply, which you may have to do sometimes a VRT as a second procedure. If you've already done resection, you have lost one muscle and gained nothing. So do application on the paretic muscle if you have to do a strengthening procedure, not a resection.
Dr. Mulli, are we done with the questions?
Yes, madam, I'm done. Hamid.
Yes,
Hamid?
done. No more questions.
Okay. So I'm sure it's been a wonderful webinar for you all with the amount of knowledge transfer which came through. Thank you. I think we are particularly lucky to have the best of best in this session. Very special thanks to the attendees who have attended this webinar and given us an encouragement to go forward. I'm very grateful to Milmet for sponsoring this webinar. Thank you, one and all. Thank you very much.
Thank you.
Thank you. Bye-bye.
Thank you.
Bye.